Hi, this is Brian Kim. I want to share with you this case of a patient who has a white cataract. It's a little bit of an intumescent capsular bag as well. This patient also has anterior capsule fibrosis, and I'm going to show you how this actually impacts my capsulorhexis. And this patient also turns out to have quite a bit of astigmatism, so we're going to be placing the Toric lens axis 110. You'll see double chop, cross chop, mechanical fracturing principles, and how I'm able to disassemble this somewhat of a dense white cataract systematically and safely in order to be as safe as I can in order to reduce corneal damage. So I'm using a cotton tip to steady the eye and then using a corneal marker to help me center and size orhexis. You can see this patient has a little bit of a Bell's reflex. This is the right eye. I'm making my paracentesis incision first on the right side and then on the left side, making sure the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. You can see the central white fibrosis on this patient. He denied any trauma, incidentally. So this is intracameral lidocaine and then some intracameral epinephrine and then some air. And then this is some Trypan blue. I'm going to try to paint the surface, but you can see there's quite a bit of stain coming out. This is because the patient has quite a bit of chamber instability. The chamber is just collapsing, and when that happens, it's a little bit harder to control the Trypan blue. I'm injecting some dispersive viscoelastic now to evacuate the bubble and to deepen the anterior chamber and to flatten the anterior capsule. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, trying to remain as parallel as I can to the cornea. And then as I tunnel and get to where I want to go, I tilt down and then enter. Push some more viscoelastic in, and then this is the sharp tip Haldane-Burkhardt forceps. I go in with the teeth sideways. I'm going to try to puncture the center, but of course, I'm mindful that there's quite a bit of fibrosis and I might not be able to puncture with the forceps. As I'm puncturing, you can see there's quite a bit of retropulsion of the anterior capsule as I'm pushing, and I'm pushing. You can see the kind of the glistening of the anterior capsule, which again suggests there's some level of intumescence of the lens there. But as I puncture, I am able to get a little bit of a tear. I'm creating the tear, and then I'm seeing there's some milk coming out. And because of that, I'm going to go ahead and push some more viscoelastic to flatten the anterior capsule, which will, again, when that milk comes out, it does mean that there's some intracapsular pressure. So I push some more viscoelastic, flatten down the anterior capsule. And what you're seeing here is I'm encountering some fibrosis. And so I stop and switch, and I use some long Van Ness scissors, and I'm cutting on the other side. So I'm going on the other side because if I try to cut along where the fibrosis is, it might actually radialize suddenly and uncontrollably. And so I decide, take the path of least resistance, go around the other way. And you can see there's some fibrosis peripherally. That's why the rhexis cut edge is a little bit irregular, but nonetheless, I'm able to have fairly good control. I stop here just to get a little irrigation, and then I'm going to that subincisional area. And because most of the rhexis has been completed, I feel more confident. As you can see, the rhexis had to go quite peripheral to get around that area of fibrosis. And so a little bit of an irregular rhexis, but at least it's continuous and circular. This is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge contra-incisionally. But as you can see, because this is a very fluffy white cataract, the lens is essentially loose anyways. And so no real reason to perseverate in this case. Lift the incision with the chopper going in with irrigation off to minimize Descemet's trauma. In these cases, the lens is essentially really loose. You don't have to worry too much about that. I'm lifting the iris up because there's some retropulsion and some reverse pupillary block, removing the surface lens material, placing the chopper under the rhexis edge contra-incisionally tilting the phaco-tip vertically subincisionally, crushing the lens in half, that is the double chop. You can see I didn't get all the way through, but that's okay. Placing the chopper under the rexus edge one more time, and then performing the cross chop. You can see that sudden loss of resistance there, and then doing the same maneuver, placing the chopper around the rexus edge, hooking the peripheral lens, crushing it against the phaco-tip, and now you can see there's a free piece. I'm able to lift it up quite easily with some vacuum, and then crushing it between the instruments into smaller and smaller pieces, and then using vacuum to emulsify the lens piece once the piece is small enough. Lifting that second quadrant up, holding it with some vacuum, and then crushing it and bisecting it, basically using the chopper to crush the lens against the phaco-tip, mashing the lens with the instruments, and then emulsifying it with using high vacuum and pulses of ultrasonic energy. I'm gently turning the second heminucleus in front of me, placing the chopper under the rexus edge contra-incisionally, turning the chopper vertically, pulling it centrally towards the phaco-tip again, essentially like a cheese wire technique, using the chopper to cut the lens and against the phaco-tip. Using that same maneuver to bisect that fragment, and then crushing the lens between the instruments, and then emulsifying the lens piece using high vacuum and then pulses of ultrasonic energy. This is the last quadrant. You can see how mobile the lens has been in this intumescent lens, placing and positioning the chopper around the lens equator very carefully and easily now, just cutting the lens in half again, essentially crushing the lens between the instruments. Again, it's essentially like a cheese wire technique because the chopper is able to cut, and the phaco-tip is really just that counterforce to be able to cut the lens in half. Again, using the analogy, it's like the chopper is a knife and the phaco-tip is a cutting board. Just mashing the lens between the instruments and then using high vacuum to very carefully remove the lens pieces. Again, this is a intumescent lens, white lens, basically no epinucleus. The bag is wide open and vulnerable to be eaten by the phaco-tip inadvertently. And that's why using sparing amounts of ultrasonic energy is very important in this case. And in this case, I'm also making sure that chopper is deep to protect the posterior capsule, making sure it's between the phaco-tip and the posterior capsule. You can see there's so much fibrotic material. I take the chopper out, push BSS in, take the phaco-tip out, and I go in with the INA handpiece. You can see all this fibrotic material within the capsular bag. You can see how helpful the Trypan blue was, but there's this really thick chunks of lens material within the capsular bag. I'm going to Cortex mode and just really trying to get that stuff off, but it just won't come off. And this is really in line with the fact that this patient has that thick anterior capsule fibrosis. Again, there's this, unusual fibrotic material all around. Doing my best to try to polish into the capsular bag, and then switching to Cortex and polish mode in between to remove as much of that material as possible. Polishing the posterior capsule as well. You can see this is a fairly dense lens, but CDE is 2.22. And again, that's leveraging the crushing forces, and that's how I'm able to have lower CDE, but using mechanical forces to crush the lens. I used the BSS cannula pulse into the subincisional capsular fornix, and that looked pretty clean. Pushing some cohesive viscoelastic to fill the bag now. And again, this is at least a continuous rexus. It's not the most beautiful looking rexus, but nonetheless, in this context, this is still a success when you're trying to position a toric one-piece lens in the bag. Using the sweep to polish under the rexus edge. Again, the capsular bag looks somewhat dirty, but it's really not. It's just that material is so adherent. And so even though I polished not a whole lot going on. There's some lens material that was able to liberate in the subincisional area, but otherwise it's fairly clean. And this is what you get when you're dealing with this kind of soft intumescent lens that's freely mobile in the bag. You're not going to have that cortex that you can just peel off like you're peeling off the skin of an orange. It's not going to be as easy. So you do the best you can to polish and clean up the capsular bag, as you can see here. I'm injecting the single piece acrylic lens into the capsular bag, and the axis is going to be 110. And so I always pre-mark the patient sitting upright in the holding area. You can see the hash marks are at 3 and 9 and as well as 6 o'clock. Go in with the INA handpiece with irrigation off, activate irrigation, making sure both haptics are within the bag, tilting the optic and going underneath it, removing the viscoelastic from underneath the lens into the capsular bag as well. And in my opinion, this is the best and only way to make sure that there's no viscoelastic in the bag. You don't want the lens to pop up while you're irrigating from the top, because there's a mass effect when that viscoelastic tries to pull out of the bag. It can cause the lens to actually dislocate. And so it's just much better to tilt the lens and get underneath the lens and then push it back down, in my opinion. Polishing under the rhexis edge one last time, making sure the bag is nice and clean. Positioning the lens where I think it's going to be, again, 110. Going to visco mode, removing the viscoelastic from the anterior chamber. You can see this is a deep chamber. This patient has a tendency for reverse pupillary block. I like to go to low mag when I'm positioning the toric lens. You can see I'm orienting the lens with the axis marker. And I'm very confident with this because when you are in low mag, you have a better view and orientation of the lens. I'm using the INA tip under irrigation, which inflates the bag, and therefore when you turn the lens within the bag, there's no torsion on the capsular bag, there's no stress on the zonules. The bag is completely opened, versus if you don't do it under active irrigation, the bag can be collapsed. And when you're turning it, you're just kind of stretching the bag and the zonules, and you're not really accomplishing anything, because when you stop, it's just going to go back to where it was. And so you have to be under active irrigation when you're trying to position and rotate a toric lens, in my opinion. And I really don't have any trouble with positioning toric lenses by doing it this way. So I'm hydrating my incision. You can see really clear cornea, well-positioned lens in the capsular bag, positioned at 110. I'm making sure that the incisions are nice and sealed. You were able to see the double chop, cross chop mechanical fracturing techniques on this white and intumescent lens. Again, I'm using the chopper, like a cheese wire, to cut through the lens material. Again, you want to think about the chopper as a knife and the figure tip as a cutting board. You're able to efficiently using crushing forces, mechanical crushing forces, this way, reducing CDE and having clearer corneas postoperatively. And you can see this patient has a perfectly positioned lens at axis 110. So I hope this was helpful to you, and I thank you for your attention.